Hello everybody, I'm George Priest. I'm a board certified prosthodontist who lives and practices in Hilton Head, South Carolina. Tonight's topic is Expedient and Aesthetic implant crowns on immediately placed implants. The importance of this topic to me is this is my routine protocol now for implant dentistry, wherever it's applicable. We're going to look at two examples of single units tonight, but I've expanded this simple technique to multiple units, adjacent implants, and even indentures patients. By way of disclosure, I am receiving support tonight from Boco America for this presentation. We're going to look at two aspects of immediately placed implants and provisionalization. First of all, with the first example, soft tissue preservation on immediately placed implants, and secondly, soft tissue development, because I'd like to make a distinction between those two aspects of provisionalization. So we'll start with soft tissue preservation. What we're trying to do is integrate seamlessly with other restorations, veneers, crowns, and natural teeth. And we're doing that in four ways. We're trying to create balanced gingival levels, a congruent smile line, proportionate tooth contours, and correct shade and optical properties. Probably the most difficult one when you're integrating implants is the balanced gingival levels, and that's what this technique is all about. So we're going to look at Frank. He's a 48-year-old male who's referred by his wife, who happens to be an endodontist. If you want to look at more detail on the techniques, you might check out the book chapter that I've done for Mike Sonic's book, Implant Site Development, the chapter that I have there. What's going on with Frank, his right central incisor is fractured. Obviously he has crowns on both of those central incisors, but if you superimpose the radiograph, you sort of see a circular defect around that right central incisor. That's the area of the horizontal fracture. And you see the little defect because Frank waited a couple of months before he came into the office for treatment. Otherwise, that probably wouldn't even be visible. We're going to replace both of those crowns, but we're going to extract the one tooth. So why do I like immediate implant placement and immediate provisional restorations? Well, there's several reasons. One, your soft tissue development or preservation occurs during osseointegration. Of course, you have accelerated treatment time. You can do it more quickly. But one of the major reasons I use this is for convenience, comfort, minimal maintenance. I don't particularly like flippers. You know, the dog ate it, I flushed it down the toilet. I don't have problems with these. It's also a great communication tool, not only between you and your laboratory, but you and your implant surgeon, be it a periodontist or oral surgeon, and of course between you and your patient. And it eliminates the logistics of having to use a surgical indexing technique where either your surgeon is going to have to do that for you or you have to be present at the surgery. So back to Frank. In this case, a periodontist performed the surgery, and number one is gentle extraction in order to preserve the bone. And that means no luxation. He happened to use periotomes to release the periodontal ligament and then use rotational movements to very gently remove the two fractured pieces, the coronal portion and then the apical portion. So what you see here is that fractured apical segment that is still there. And that took him about 20 minutes to tease out because we don't want to disrupt that buccocortical plate. And notice it's a flapless procedure that the sulcular tissue is still present. So here is the socket after the tooth was extracted. And there's that coronal portion that was taken out. The implant was positioned using a rule or a mnemonic that I call the 3x3 pi rule. That simply means that I'd like the platform of the implant 3 millimeters apical to the gingival margin or the anticipated gingival margin, and I would like the center of the implant at a minimum of 3 millimeters in the palatal direction, which is going to leave, if you have a standard 4 millimeter implant, at least a millimeter between the buccal aspect of the implant and the cortical plate. You don't want to touch that cortical plate. This is a tapered platform switch type of implant that's being placed by my surgeon. What he's doing here is filling the gap. There's a little bit of space again between the buccal aspect of the implant and the cortical plate. You want to fill that in with either autogenous bone or bone substitute, not to prevent ingress of epithelium. That's not going to occur, but to prevent that what the Manias call the umbrella effect, to keep the buccal contour, facial contour there so you don't get a shadow underneath that implant or implant crown. So he's grafting that area. Now he's also placing a membrane. He's tucking it between the cellular tissue and the cortical plate because of that little defect, that horizontal defect. Was it absolutely necessary? I don't know. It certainly didn't hurt anything. I wouldn't, if this is the first time you're doing immediate provisionalization, I would try to do it on a patient that doesn't require any grafting. But he's tucked that membrane in there and then placed the healing abutment until the patient comes to my office, which is probably a half an hour away. So he had this healing abutment on for half an hour. The surgeons that I use typically will use Marcaine or a long-lasting anesthetic. That way the patient does not have to be re-anesthetized when they come to my office. I had previously made an impression of Frank's teeth, and from that impression I made a clear matrix, just what you might call a vacuum suck down. And that's what I'm going to use to make this provisional restoration. This happens to be a Biomet 3i implant, and this is their temporary cylinder, not a temporary post. I want to use screw retention for the provisional restorations. So I place that on the implant. You can see the alignment is very nice. Very little trimming. What I want to do is keep that cylinder about 1 millimeter short of the incisor layers, just so I don't get a show through. And of course you want to keep it out of occlusion. So once I've trimmed that, and I did that on the implant, it was a very stable implant, then I try the matrix in over that to make sure that I have the required clearance. I'm going to show you a video on a cast of what I do next. I'm going to place a hole through the palatal aspect here. It's going to be in line with the implant. So look at this little video. Just a number 8 round burr is adequate. So I go through that clear matrix. By the way, the clear matrix extends about a tooth to either side of the restoration that you're going to make. And make the hole big enough so you have easy access for your screwdriver. So here's the hand driver. And it's a very low technique. I'm simply going to use a cotton applicator stick to fill the access openings so we don't get our resin into the screw hole. Leave a 1/4 inch to 1/2 inch of the stick protruding so you can easily grab it. So place that in your access opening after you place that temporary cylinder in place. So we're going to use bisacryls. The particular product I use is Structure Premium and occasionally Structure 3. And the reasons are you have a much faster setting time with your bisacryls. You have Luxatemp, ProTemp, the other materials. I particularly like the Structure Premium and the Structure 3. But for example, your bisacryls, only the setting time between the Structure 3 and the Premium is 45 to 90 seconds as opposed to about 5 minutes with your jet acrylic resins or similar methyl methacrylate resins. The optical properties and shades are a little more lifelike. You have better translucency. And they're stronger, more durable. I've been doing this technique for several years now, and this is why I like the Structure. I just want to stay with a good thing. I have not had a fracture yet on one of these restorations. That's not to say I've never had an implant failure, but certainly have not had one of these fractures. And if you do get a void when you're making these, you can quickly fill the void with flowable composite resin. You don't have to wait another 5 minutes, for example, if you were using jet acrylic resin. So here are the resins that I'm going to use. I use the Structure Premium, and to fill the voids, I use the Grandioso Flow to fill those voids. And here's the Structure 3. The advantage of Structure 3 is you really don't have to polish it. But I tell you where I really find that advantageous is when I'm making provisional veneers, more so than with the implant provisionals. All right, so back to Frank. I filled that matrix with the structure premium. I placed it over the little stick and you hold it in place for the duration. In this case, it's 90 seconds. Don't remove it until the 90 seconds are up because you don't want any distortion. After about 20 seconds or so, tease that stick out of there so it doesn't adhere to the resin. And then place your driver. So let's look at another video to illustrate that. So you set the timer, inject the Visacryl. You have the matrix seated over the stick in the provisional cylinder. After about 30 seconds, remove that stick and place the driver, and then remove the restoration at the prescribed time. So let's take a look at this. You can inject a little bit of the resin around the cylinder too to make sure you capture it. So place it over, make sure you have it lined up where the little cottonwood stick protrudes through the little opening that you've created, aligned with the axis opening. After about 20 seconds, simply remove that, and then place your hand driver, capture the hex of the screw, but wait until the prescribed time before you unscrew it and take it off. It's usually going to come out pretty much like this. Sometimes the matrix will come off first and then the provisional restoration. Take it out, let it sit for a couple of minutes before you start to manipulate it. Now this material is very accurate, so you don't have to be careful when you're adjusting the contact areas. Adjust to the contact, but don't touch it because it's going to be pretty accurate. So you're going to get a little void around here because the tissue is going to collapse, but that's where you want the support. That subgingival support is what's so critical. So you add flowable composite there and set that quickly with the light. Visacryls don't like carbides, they don't like diamonds very well. So what I use are metal impregnated rubber wheels. And the one I particularly like, it's a Comet product, but all the companies make them. So I've got a little kit here, but for a single tooth restoration, you only need this one wheel. You don't need the others. They're for multiple units. So you have this wheel with the metal filings in there, and you trim the restoration down. So you can see I've tried this in. You can see where I've shaved some of the facial off because it was fat. But here's the concept. We're preserving the tissue, we're not developing it. Remember that this patient had a flat-face procedure. The sulcular tissue is there. All you're doing is re-supporting it. You're trying to preserve it. You're not doing any magic to try to develop the soft tissue. You're simply trying to keep it where it is. All right, so after it's set for a few minutes, you're going to trim it with this universal polisher and add flowable composite to any deficient areas, and then you're going to refine and finish it. I simply use wet pumice wheel to polish it, and then a high shine with whiting or luster on a lathe as well. So notice when I'm trimming or polishing this, I'm not touching the contact area. You want to preserve that. In this case, I'm adding the flowable composite after I've done my basic trimming, but usually I'm going to add the flowable composite first. So the subgingival contours are what are critical. I want to show you how best to adjust those contours to re-support the tissue. So in this case, the next thing I'm going to do is add some flowable composite. Notice also in the previous picture that the implant was placed in such a way that we could easily use a screw-retained restoration. It comes up right through that palatal incisal edge. That's what the PIE stands for. You don't want to do the cingulum. That's too far to the palate, but a little bit facial to that. So I'm doing my basic trimming. You're really just connecting the dots from the round cylindrical implant to the three-dimensional form, trigonal form of that tooth as it emerges from the sulcus. All right, so here's how it works. There are instances where you'll actually want to move the sulcular tissue in an apical direction. In order to do that, you're going to increase the subgingival contour of the restoration. You can either add some material or leave a little bit of bulk there. That will push the tissue apically. But probably more often than not, you want the tissue to migrate coronally. So in order to do that, you're going to decrease this facial contour. Of course, you're limited to an extent because you don't want the contours to be visibly different from the contours of the adjacent teeth. And how much tissue can you get? I mean, you're not going to get 3 millimeters, but you can make a millimeter difference, which can be the difference between success and failure in the aesthetic zone. Now, when you get to the papilla, it's a little bit different, and I think of it as I would of orthodontically moving teeth. As you separate teeth, for example, 2 central incisors, the papilla would flatten out. As you orthodontically move them back together, they are going to move coronally. So that's essentially what we're doing over here. If you want to flatten the papilla, which is rare, decrease this contour, you'll have an increased area for that volume of tissue. It's going to simply flatten out. On the other hand, if you want to increase the height of the papilla, you increase the subgingival contour. Of course, you want to open the contact area a little bit, and it's going to move coronally. And just another piece of refinement here. Remember, you want your zenith to be angled distally. So in order to do that, increase the distal contour. It will push the tissue apically in that distal dimension, keep it a little more under contour on the mesial, and it'll migrate more coronally. So that's all there is to it. You only have to try it in once or twice, and you're probably going to look pretty good. So here is Frank's provisional restoration after it's completed. Nice smooth contours, a smooth emergence profile, no abrupt changes in the contour. But remember what we're doing, in this case, we're preserving the soft tissue form. Frank's soft tissue had adequate contours. I don't want to change that. I just want to keep it where it is in order to be confluent with the tissue on the adjacent central incisor. Now, there's some rules to follow, though, if you're going to place an immediate restoration. And I modified these from a review from Gruder and Erzbelzer. First of all, you want to have a relatively ideal bone volume where you don't have to do a lot of grafting and where you can get good initial stability. They recommend 40 Newton centimeters or more of initial seating torque. I've gotten to where I'm happy with 30. We've restored many restorations with a minimum of 30 Newton centimeters, and the success rate seems to be the same. I like to use screw-retained provisional restorations and make sure they're out of functional contacts, both in habitual occlusion and in excursive movements. Now, you don't want to remove this restoration for the healing period of at least 6 weeks because you're going to lose some of that stability as the osteoclastic activity begins. So place it in there, tighten it down, and leave it. I'm really stringent with the rules for the patients, and I do that just to make sure we have good success rates. I asked them to stay on a soft diet for 8 weeks. No brushing in the area for a few days, and then just soft brushing for 2 weeks. After a week, gentle flossing. I don't know if it really makes a difference, but it appears to. I place the patient on chlorhexidine, have them rinse with it twice a day, usually in the morning and in the evening, until they come back for the impression at least. Why do I want to screw retain provisional restoration? First of all, it's easier to remove one component during the adjustment rather than an abutment and a crown. Importantly, your emergence profile begins at the abutment level, at the implant level. Let me show you why. If you're using a temporary cylinder, your margin, your material can go all the way down to the implant, at the head of the implant. So you can develop that far down. So down to here. Now, if you're using a cementable post, here's the problem. You've got your post, you're limited by your cement margin. So your depth can only be so far on preparing that. So it's probably going to be in this area. So that, apical to that, you've really not developed the soft tissue ideally. Of course, you're not concerned with cement margin with your screw-retained provisional. And in cases where the tissue has already healed, you can gently expand that tissue by slowly tightening the screw without torturing the patient. There's several different kinds of impression techniques that you can use to capture that soft tissue detail that you've developed. But here's one way that I do it. It's a little more time consuming, but it works very effectively. I impress the provisional restoration with the polyvinyl siloxane or polyvinyl siloxane ether. Then I'll attach an analog to the provisional restoration, plug it into that impression, then inject a matrix material around that. I then pour that, while the patient is still there, in a very fast-setting stone. So here's that provisional restoration on there. So now I'm going to very accurately capture that soft tissue detail, and there's no guesswork for the lab, except the patient's going to have to wait around for half an hour or so while you do that. I'll then take that off of there, and you now have a very accurate cast for your lab to fabricate the abutment and the crown on. It's not just the provisional restoration. Your soft tissue preservation is a result of, first of all, a good site, flapless procedure, flapless surgery, ideal implant placement. In this case, we did a platform switch. I'm not sure that made that much of a difference. Excuse me. So we're going from this on Frank, there's that initial radiograph, to this. You can see that I've actually tried to distalize the software area a little bit. It's actually more ideal on the implant restoration than it is on the natural tooth. But really, we have pretty coincident soft tissue levels. So this is several weeks after placement. I've superimposed this radiograph here. This happens to be a platform switch type of implant. And you can see that in this case, we have bone all the way to the top of that implant. And of course, the bone, preserving the bone, is what preserves that soft tissue. And of course, we've duplicated that soft tissue form in the cast, so we'll be able to make a crown that's going to mimic the contours that I've used to develop that soft tissue. Of course, I'm going to get good shade selection images because we're matching these two central incisors. So I went to one-to-one pictures of the lateral incisors that I'm going to try to match. And you want the tabs adjacent to the teeth with the numbers of the tabs clearly displayed. These happen to be 3D 3L1.5. And I'm going to customize a little bit. Here I'm using Ducera modifiers. What we're using now is Noritake. It's a very good material for both your Emax and for your zirconia crowns. These particular crowns are not Emax. All our abutments are virtually designed. So in Frank's case, this is done using 3Shape. And you can actually look at these files yourself. You don't have to pay for the, you'd have to pay for the design software, but for the observation software, you don't have to pay for it. You can look at the design of your abutment if you want to approve that before the lab has it milled. And you can see the articulation as well. I'm sorry, let me go back one. You can observe the articulation as well. You can manipulate this in 3 dimensions and make sure that your lab is providing the clearance that you need for that restoration. So here is the virtual design zirconia abutment. There's the adjacent crown. Now I have both crowns in place on the cast. So here's a close-up of the provisional restoration in place. And notice you have nice stippled pink tissue, nice soft tissue health. I've taken that provisional restoration off, and you can see how we've developed the tissue, or not developed, preserved the tissue from that round implant up to the three-dimensional form of the tooth. I've seated the zirconia abutment and tightened it to 20 centimeters. In this case, I filled it with a clear silicone called Memosil, but what we're using today is Teflon tape. Here is Frank prior to treatment, and here are the restorations afterwards. So you can see certainly the soft tissue profiles are very clinically acceptable. You'd really have to look not to know that that was an implant restoration. He's had this about 3 years now. I just ran into him in a store the other day and had him retract his lips so I could look at it. He's doing quite well. So that's an example of soft tissue preservation. Here's the radiograph, the platform switched implant. Of course, the zirconia is going to be radio-opaque, and here's the baked porcelain over that. And here is the zirconia cord crown on the adjacent central incisor. As you can see, we preserve that interceptal bone very nicely, which gives us the papilliform. Got a couple of questions here. Do I torque down the screw holding the temporary? I don't, and I'll tell you why. You're not going to torque down greater than 20 newtons. You should have significantly more than 20 newtons initial torque. If it makes you feel better, you can hold on to the temporary, but you should not turn it. If it does start to turn, stop and don't go any further. And I've got a question, is that a 3i performance post? It's a 3i performance cylinder. In Frank's case. The post is used for cement retention, which I don't necessarily recommend. All right, so we've looked at that one example. So we'll now look at a second. Again, the reason for the screw retained temporary crown is it's easier to manipulate one piece instead of two. Probably the most important reason is you don't have cement. So you don't have the potential of cement in a freshly placed socket, which can cause a fissure. You can really mess up the soft tissue. So that's the primary reason. It's just easier as well. Now we're going to look at soft tissue development. We've been talking about soft tissue development for years. I think that for the most part with our flap surgical procedures, we've been preserving soft tissue. So now I'm going to show an example using this technique where we actually do develop a soft tissue. This is Angela. She's 33 years old. She has agenesis of the permanent right canine. She has a deciduous canine in place. She went to another dentist who strongly suggested orthodontics. And I can see the point, but she's sort of holistic. She doesn't want to do any more than she has to. She likes her smile otherwise. I don't see the need for ortho. She needs to clean up her act a little bit, which we did. We went over that with her, and she's taking good care of them now. But if you look, this is not the soft tissue profile that we want. We want a profile that's going to look like this canine here. So we're actually going to develop the soft tissue. Here's this deciduous canine, and notice it's in palatal version, whereas the permanent canine on the left side is in buccal version. It's the radiograph. It's just it's undergone replacement resorption, so we have a good site here. Simply have to take that little vestige of a tooth off and then place our implant in that area. All right, so if you look, that one canine, even though it's a single tooth, it's critical aesthetic because it's done two things. It's created an imbalance in the soft tissue levels. And you compare that to the other side. And it's also caused an incisal imbalance. When you look at it from the occlusal aspect, you can see the position of that deciduous tooth. And it's also a little more narrow than the position of this tooth here. She's obviously not in a canine-guided type of occlusion. We're going to keep her in a group function. Now, when I work with my implant surgeon in this case, I predicated the implant placement on where I want the tooth to be, not where it was. If you look where I put the axis opening using the 3x3 pie rule, I'm almost out to the facial aspects of these adjacent teeth. So the implant is going to be even further out. I'm doing that intentionally because what I want to do, I want to mimic the contours both of the hard tissue and the soft tissue of that contralateral tooth. So I had the laboratory wax my surgical guide. You can do this with virtual placement as well, but this is a handmade surgical guide. So here's the tooth out in a facial aspect. I also scribe a line on the facial aspect of the guide just to give my surgeons a little more guidance. Again, using the rule of 3 by 3 pi, 3 millimeters apical to the margin, 3 millimeters palatal, and through the palatal incisal edge. Notice it's not out to the incisal. It's not way back in the cingulum like we did when we first started doing single implants. It's a little more facial than that. Keeps that implant a little closer to the buccocortical plate. So my surgeon again used a flapless procedure, took that deciduous tooth out and placed that implant exactly where I indicated with my surgical guide. All right, so here's a facial picture of that implant. So just like the other patient, Angela came directly from to my office after this procedure. A long-lasting anesthetic was used, so I didn't have to re-anesthetize her. And there's the implant in place with the healing abutment. Right, here's the concept, and this is something I've talked to Marcus Hertzler about a few years ago, and I've been intrigued by this process ever since. Your implant position certainly affects your sulcular levels. So what I'm trying to do here, if this is the patient's ridge, this is the vestibular area, this is the palate. So if you're looking across there, if this happens to be this area where this canine is, if I put that implant, or have the implant placed right where the canine is, my soft tissue level is going to be about here, where it was previously. But look where the soft tissue level is on the other tooth. It's much more apical. So in order to do that, of course, I want to move the tooth out buccally too. So for two reasons, I'm going to request that this implant be placed more buccal, because it'll do two things. First of all, it'll bring the canine out to the buccal or facial aspect. And secondly, it's now going to move that sulcular level more apically, more in line with that contralateral tooth. So in this case, we are developing the soft tissue. We're changing, dramatically changing it. Here it is after some healing, a few weeks healing. So you can see the contours of my provisional are very similar to that of the natural tooth over here. And even pushing that implant considerably to the facial aspect, we have nice buccal contours. It's moved apically. We almost move a little more apically to completely idealize it. But you understand the concept. We moved it facially intentionally to develop that soft tissue. What type of implant was placed flapless was the question that was asked. In both of these examples, these were Biomet 3i implants. I do work for Biomet. I'm not right now, but these both happen to be Biomet. The first one was a certain Prevail. This one happens to be a certain tapered implant. It's not a Prevail type implant. We're not going to platform switch on this one. All right, so now you can see that the soft tissue levels now are much more coincident. Now I probably, how long does it take to do this technique? I can typically do it in about half an hour. In Angela's case, I spent probably 40 minutes or so because I really wanted to refine this apical or subgingival portion to get that soft tissue looking as ideally as possible. And I wanted to copy the contours of that contralateral canine as closely as I could as well. In this case, I used the structure 3, just because it sets even quicker. I'm not watching my life pass away while watching a little timer. It's only a 45-second set time. Here's the screw retained provisional in place immediately. You can see the blanching of the tissue because it's going to be a larger sulcus than what we had around that deciduous tooth, and I've moved it facially. So I've superimposed that picture, so it's this subgingival form that is giving me the contours of the soft tissue that you see. So remember, it's your subgingival contours of the restoration that are critical to the soft tissue levels. What happens above the tissue is not that critical other than for hard tissue aesthetics. Here it is from the occlusal aspect. What I typically do is place Teflon tape down into the access opening after I've torqued it down, Then I'll place a little layer of flowable composite over that. And that's going to stay in place until we're ready to make the impression. Once again, here is that provisional immediately after seating it and tightening it down to 20 newtons. Here it is 12 weeks later. You have nice stippled pink tissue, nice circular form, nice papilla levels, and a pretty good blend with the provisional restoration. That's another thing I like about these Visacryls and the Structure Premium N3. Yeah, I don't customize the colors on the provisionals. You get this nice transition as you go up to the thinner areas. It starts to look translucent, and you get nice colors, and patients have certainly not complained about the color of their provisional restorations. So from the frontal aspect, you can see, again, immediately after placing the provisional restoration, and here she is after 12 weeks. Nice flat tissue, nice buccal contour. You don't see that shadow effect. And again, it's a primary result of very gentle surgery and ideal implant placement. And then the third aspect of that is the subgingival contours of your restoration. So I've been able, this is a good communication tool because now the patient can see exactly where we're going. And I'm trying to create both incisal and gingival balance in the aesthetic zone. You can see we've got fairly coincident gingival levels and good incisal form too. And Angela's happy with that. Can you do the same method with acrylics? Sure, you can use acrylics like jet acrylic, methyl methacrylates. They work fine. They just take longer to set. I'm not sure they're quite as strong, but yeah, you can use those. So I use jet acrylic today. I'm doing 6 anterior units of crown and bridge. So I'm not saying you can't use them. In Angela's case, did I use a tissue additional contouring because of gum deficiency? No, I mean, when we first placed it, it looked like the tissue was really apical. Maybe I was lucky, but the tissue actually migrated coronally on its own after those 12 weeks. There were no grafting procedures done whatsoever in this case. You know, sometimes we just get lucky, don't we? The only time you remove that provisional restoration is to make the impression. One more question. Do I find balance in the occlusion in the canine area site more demanding than other aesthetic area sites? Any thoughts? Well, the occlusions, in this case, yeah, because her other canine was out to the buccal and she had a deciduous canine on the right side. She did not have a canine guided occlusion, so I was not going to build that in this case. We kept her in a group occlusion. If I'm not using a performance post, am I using a gingival abutment? I haven't used a gingival abutment for a long time. I'm pretty much sticking to the performance post. You could use a gingival. I think it would work fine. All right, so let's look at this. Here's that provisional restoration. You're going to get a few bleeding points when you take it out. That's actually a good thing. I learned that from Stephen Chu when we were talking. That means that you're getting some hemidesmosomal attachment to the provisional restoration, which is helping to hold that tissue there. So the only time I remove that is to make the impression because you're creating a little bit of microtrauma and you want to minimize that. Now look, here's the other reason you don't want to remove it. If you look at this graph, you have on the left what's called initial bone to implant contact. On the right is your biological bone to implant contact. So what happens when you, say you place your implant and it's torqued down to 50 newtons, well, over the ensuing several weeks, during the reformation process, the osteoclasts are going to get in there and eat away that bone. This is initial just a mechanical stability. You're going to lose some of that. But then the biological process of the osteoblast attaching, the fibroblast attaching, that occurs, so that increases it. So if you superimpose these two processes, you have a graph that looks like this. So if you manipulate this restoration, say at 4 weeks, you could deintegrate the implant. So once it's in there, leave it alone for a good 6 weeks, and then if you really feel compelled to adjust it, you can. Again, I fill the access opening of the provisionals with Teflon tape and just a little, maybe 1 to 2 millimeter layer of flowable composite. It's very easy to get that out to make your impression. If the patient's a smoker, I ask them not to smoke for at least 2 weeks. Of course, you try to get them to stop smoking, but I really do believe that if they smoke right away, it can affect the integration of the implant. And how do I communicate the shape of the self-assisted lab? I'm going to show you that in a minute. You're right, the tissue tends to collapse after you take the temporary off. So I'm going to show you how to capture that soft tissue. So we're going to look at that now. All right, we've got this provisional restoration in place. You're going to remove the provisional restoration. If you want to, you can place a healing abutment in here because the tissue will collapse a little bit. I'm then going to attach an analog to the provisional restoration. This happens to be, again, a Biomet 3i. It might be hard to see on your screen, but this is their blue analog for the 4.1 millimeter certain platform. I have my assistant mix silicone putty, and I'll take this whole assembly and just plug it into the putty. This is actually her contour after I've taken it out. You plug it in there, allow that to set. This is just another way to do it. There are many ways to do it. Could you use Cabot as opposed to Teflon tape and flowable composite? I think so. If you're going to use Cabot, though, put a little cotton pellet over the screw access opening first, because you might dig up the head of the screw trying to get all the Cabot out. All right, we're going to look at a little video here. I think we've got it. This is another patient, but you mix up your little silicone putty. This happens to be a central incisor. Push that into the putty and make sure you capture at least the gingival third of the crown, because you want to get those subgingival contours that you've developed. The putty takes probably 3 minutes to set, 2 to 3 minutes. After it sets, unscrew it. So take the provisional restoration out. And there's the form that you've developed. Let me see another question. If the acrylic gets into the osteotomy that's prepared, then it is harmful for the gingival area or bad for the gingival growth towards the gingiva. The acrylic gets into the osteotomy. And if you get fresh, unset acrylic down there, it sets below the tissue as not as part of the provisional restoration. I can see where that would be harmful. But your polished provisional restoration, whether it's acrylic or your bisacryls, it's not harmful to the soft tissue. All right, let's go to the next step here. So I've captured that sulcular form in the impression. So the next thing I want to do is make a custom impression coping. So let's look at the central incisor again. So here's that three-dimensional form. This is the facial aspect of that central. By the way, what I do now is I mark with a magic marker like buccal and lingual, just so I keep this oriented in the right way. You place a pickup impression coping on that analog that's in the putty. Then you can either use a flowable composite, that's pretty quick, or you can use a GC resin or another type of resin to fill in this void. I'm using the flowable composite. Inject it in there. You might do it in a few increments to make sure that you get it light cured all the way down to the base. So inject some in there. Light cure it. Now make sure that you capture the flats here. If you only capture the round part of the implant, it could rotate on there and be inaccurate. So make sure you come up at least on one flat to lock it in place positionally, rotationally. Then you can cure it and remove it. All right, so back to Angela, that's what we've done. All right, so we've done the same thing. I've added that flowable composite to the custom impression coping while it was in that putty. I removed it from the putty. So now I have the exact contours that I've developed for the provisional restoration. So that's how you communicate that to the lab. So I'm going to seat it on the implant. All right, so you can see there's just a very minor amount of hemorrhage, very little. But you can see the sulcular form is still there. Then you make your final impression. and you take it out, and you can see you've got all this nice subgingival form, and the lab now pours that up with a gingival matrix with a soft tissue cast, and they simply have to fill that void. They don't have to guess or estimate what the contour should be. This is critical to me too. It's a technique that I call scripted shade and contour images. I've gone to my lab a few times, and I've noticed that they've all got computer monitors there. Now remember, Angela, even though it's a single canine, I really want to get this color and contour just right to match that other tooth. So what I do, I notice the lab, they're looking down at the lab, so then they're looking up the monitor back and forth. There's something lost in translation there. Send out very simple programs. There's iDraw for the Mac. There's Adobe Photoshop Elements. That's a cheap program you can use with your PC or a Mac to add scripts to your actual JPEGs and send those pictures electronically. What you can see here, I'm sending them a picture of my actual contour so they see that. My basic shade guides, I want them to shade tabs. These are the Noritake custom tabs, just lots of pictures. I take the pictures, I usually format them at night. It might have taken me 10 to 15 minutes to do that, but it comes back in spades. You really get nice color renditions when you spend that little bit of time. So in this case, we're making an all-ceramic crown. This is an Emax crown. Here's the access opening, so the definitive restoration is also going to be screw retained. Whenever I can now, I've reverted back to screw retention because now I can do it with all ceramics. But it should mimic that provisional restoration for balance. So we have a titanium base, the rest is ceramic. Now when you look at it from the facial aspect, here's what you see. And if you peel away that soft tissue, these contours simply filled that void to support that tissue that we've developed with the provisional restoration. Now, why am I reverting back to screw-retained crowns and restorations? There are several reasons, several good reasons. One, you still have the aesthetics of a ceramic restoration, where in the old days, when we first started doing this, we were doing it with metal ceramic crowns. And which type of Emax am I using? I'm using the Emax Press, but the Emax CAD is fine too. If you're making CAD CAM crowns, I simply still like the aesthetics of hand-applied porcelain, so we're just getting the core made with the CAD CAM procedure. These are not UCLA abutments. They are, gosh, a good question, Stuart. They're titanium. They might be titanium bases from temporary cylinders, but I'm not absolutely sure. But it's a procedure that my lab is using. All right, so we've got the aesthetics of a ceramic restoration. This is really critical. You eliminate that residual, that potential residual cement, which can wreak havoc on the soft tissue. Now, I restore patients as young as 17 or 18 with implant restorations. You want to plan for that eventual recession. So a deeper ceramic margin with a screw-retained restoration allows you a couple of millimeters of depth at least, which is a mile when you're talking about soft tissue recession. Number 4, you only have one margin instead of 2, which could have soft tissue implications. Very predictable retrievability. Many times if you have a cement-retained crown, even if it's provisionally cemented, you might have to cut it off. These, if I have a little ceramic fracture or something, I can easily retrieve it and repair it or reapply porcelain. And finally, these are particularly useful if you have a shallow sulcus, where you don't want to get that show through, or if you have a thin biotype, same thing, to prevent that so-called gray zone. Angela returned for seeding of the crown. I'm going to show you the day of seeding, because you remember the soft tissue form is already developed, so you simply seed or slip that definitive restoration into that previously developed sulcus, and you should not have any blanching or inflammation. All right, let me go back. This is the provisional restoration in place, But let's go back to the beginning. Here's what she looked like prior to restoration. Here we are immediately after seating it. Immediately after seating it. And here's her smile, retracted view. This is probably after 10 minutes. Maybe when I first put it in, a little bit of blanching, but it looks really healthy immediately. Radiograph. Again, you can see this is a titanium base with a little bit of sliver up here, and then the porcelain is baked to that. I've not had one of these fracture or dislodge yet. All right, if you look at this close-up, you can see we have good healthy tissue, a pretty good shade and contour match with the contralateral tooth. A question was asked, it's a good one. If you're an implant surgeon, what does your implant surgeon do if you want the screw axis hole too far buccally for the bone? I mean, then you have to make concessions. You might have to angle the implant. In that case, you probably can't use a screw retain provisional, and you would have to use cement retain. I use this process whenever I can, but if ideal alignment is going to cause a dehiscence or a fenestration, then we have to adjust a little. Good question. All right, so back to the smile line. From the occlusal aspect, this is what we had prior to restoration. Here's the screw retain restoration. Now, when I place a definitive restoration, again, I place the Teflon tape in here first. Then I'm going to take a dime and make a little undercut about 2 millimeters down in the axis opening, and then fill it with my flowable composite. The reason is, I've just learned over the years, these things will indiscriminately pop out if you don't mechanically lock them in. The patient could be embarrassed or something and think that the world is falling apart. Even though it's not a big deal, it concerns them. So by placing a little mechanical undercut, you're assured that it won't come out until you want to drill it out, if that's the case, if you want to remove it. All right, here's Angela's smile preoperatively. Here it is afterwards. All right, so you see the before and after smiles. And look, I really worked with my orthodontist closely. I really don't think it was indicated. Shouldn't say it's not indicated. I'm happy letting the patient have her own way. She has no symptoms of TMJ problems, no muscular tightness. What I'm trying to do by creating a bilateral asymmetry, in other words, I'm trying to create the asymmetry that she has on this side, and by doing so, we're getting balance. All right, a couple more questions. Do you have any with ridge laps on the facial buccal? Gosh, when I first started doing implant dentistry, when we went through the cingulum, I had a few ridge laps, and they looked awful. That's why I asked for the PIE, palatal incisal edge. I don't want to go as far back as through the cingulum. That's when you end up with a ridge lap because the implant is too far from the facial contour. That's exactly right. Can I elaborate on how I use the Teflon tape? Teflon tape is a real malleable, soft material. It's actually plumber's tape, so it's cheap. You simply use a packing instrument and pack it in there. It bunches up very nicely. And then you place you pack it in, then place your composite over it. What I love about the Teflon tape, whether it's a provisional or definitive crown, when you take it out, you don't have a smelly mess like you do with a piece of cotton. It comes out very cleanly and easily. Right, and the Teflon tape does not smell. That's exactly right. I favor screw-retained temporary crowns and screw-retained permanent crowns. Why not? Why not? I'm not sure I answered the question. I do prefer screw-retained temps and screw-retained permanent crowns. Cemented crowns. Again, the biggest issue with cementable crowns, there are two. One, not as predictable retrievability. Number two, you have a cement margin. Remember the 6 reasons that I told you. You can place a much deeper margin with your all ceramic screw retained crowns. I just read a good review in the International Journal of All Maxillofacial Implants. No difference in the prognosis of the implants whether you use screw or cement retain. So that's more verification to use that technique. Why extraction of the canine instead of ortho? Remember, this was a deciduous tooth that we extracted. It was failing. It was very mobile at this point. She waited till the last minute. So remember, this canine was a deciduous tooth. That's why we didn't treat that orthodontically. Could you use wax in place of the Teflon tape? I suppose so. It's really soft. I don't know that your composite resin might collapse over it. I've not tried it. You could give it a try. How is it going to solve the problem of very thin alveolar bone facially? I mean, this technique is not going to solve that problem. If you have thin facial bone, you've either got to stay away from it, or if it's deficient, that area is going to have to be grafted to get the contours first, either at the time of surgery or before the implant is placed. Where exactly is the Teflon tape placed? All right, when you screw your restoration into place, the Teflon tape is the next thing. So say the access opening is 4 millimeters deep. I would pack the Teflon tape in about 2 millimeters. And if you have too much, pull a little out and cut it and then pack it in again. And then place your composite resin over that. Do I use bonding agents or soliding to close the access? No, I really don't, because it's the bonding agent is going against the ceramic. It's really just a mechanical seal. We've got a few more questions. Let me get to the last slide or two here. All right, here's Angela's smile. So you'll allow me to use her facial picture. I think it's a very aesthetic smile. So she's still teaching her yoga, and she's going through her diet supplements, doing quite well. Let me go through the conclusions, then we have a few minutes for some more questions. Immediate implant protocols, they are keys to your aesthetics, convenience, your patient comfort. Patients love these things, by the way, and your patient-lab communication. These are critical tools at the time of immediate placement for either soft tissue preservation, as I showed you with Frank, the first patient, or soft tissue development, as you saw in Angela. And you want to select materials and components that optimize the longevity, expediency, and aesthetics. You know, knock on wood, I've not had a single, I'm talking about single crowns now, and I've done hundreds of these, but I haven't had a single one fracture. We've had implant failures where the whole thing comes out, but not one of them is fractured.